note that as always. So welcome everybody. Delighted to see everybody as ever for our Council of Governors meeting. And I know a number of colleagues have been involved in a workshop this morning, and I hope everyone's made it comfortably back into this formal part of our Council of Governors meeting. So we have apologies today from Roshni Khatri. Obviously, there's a few other people not with us today, and we'll review those subsequently, but certainly apologies from Roshni, but also apologies from Angela. She's attending an integrated care board meeting, but as ever, we've got Dave Mayer here today, very ably taking the hot seat from the Chief Executive. So Dave will be leading the Chief Exec's report item later on. So declarations of interest, reminder to send any changes to your declarations to the corporate governance team. But is there anything specific that anyone wants to declare in relation to items on the agenda today, just for noting in relation to our particular agenda today? I take it that's a no, so we'll note that accordingly. So in terms of other standing items, we have minutes of the previous meeting, the last one held on the 4th of January. Just want to check with colleagues if they're happy it's accurate, and therefore, if it is, are we happy to approve it? So I'll pause for a moment in case anyone wants to highlight anything. Everyone content that the minutes are accurate, so I'll take that as a yes, and we will approve the minutes from January. In terms of action log and matters arising, you're welcome to raise anything from the minute that you'd like to that perhaps we hadn't captured on the action log, but if there isn't anything on that, there is just one outstanding action which relates to taking the council through a sort of topic of health inequalities, I think is the intention behind that action. We haven't managed to accommodate that currently on our work plan for the Council of Governors workshop. So very much more, rather than something we were intending to bring to the formal council meeting, we thought it was appropriate for a sort of workshop type discussion. So that's still on the plan. I don't know if we've got a long list of items, Tracy, we can just add that to rather than keep that outstanding on this action log. Is there a working list of things we want to include on the programme of governor workshops this year? So perhaps we can add it to that and confirm that we've done that for the next meeting and then plan accordingly. Right, Richard, do you want to come in?
Just briefly, Krishna, yes, whilst there is some further conversation that the council will want to have about health inequalities, I was just also going to flag that we touched on this topic at the recent workshop that we had with colleagues at KGH. So we did get to explore population health and some of the key metrics concerning health inequalities at that workshop. But yes, certainly more to come in the new financial year, but I thought that was a relevant point to raise. Thank you.
Absolutely. Thanks, Richard. That's really helpful. Great. Okay, so if there are no further queries or comments on the minutes or outstanding actions, we'll move on to our first substantial section of topics. And today we start with council matters, which is obviously the Director of Corporate Governance report. So actually, back to you, Richard, to lead us through that report. Thank you.
Thanks very much, Krishni. Good morning, everybody. I'll refer to paper D in your packs, which I shall take as read. I'll draw out sort of three areas from the report, and as usual, very happy to take any questions and comments and contributions from colleagues. So the first, as we come to the end of the financial year and also the end of term for several governors, I thought it was really appropriate to thank governors for their contributions to the trust and indeed to the system over the past year. These reports provide a window into just some of the things that governors collectively and individually have achieved together, and I'm sure colleagues would agree, there's been an awful lot of activity actually this year, which is making a really positive difference. So I particularly like to thank those governors that will not be continuing in their role, and to encourage them to remain connected to the trust, either as a member and indeed through various other means in the coming year. The second area, as you can see from the report, we are almost at the end of our annual governor elections programme. I am pleased with the level of interest we managed to generate in this year's elections campaign, which is now moving into the final stage, and we look forward to welcoming new governors that will be joining the council via the induction process that we've got scheduled, I believe, in May, which will be face-to-face. But despite an overall positive campaign, where we are hoping to fill most of the seats that we had out, we do end with several remaining vacancies in the patient and carer constituency. So we'll reflect on some of the lessons learned from the campaign, and then come back to the council for a further discussion on what actually we might need to take to ensure good representation in that constituency into the future, and that will come back at a subsequent council meeting. And then the third area I wanted to highlight was relating to membership activities, both achievements and also priorities for the coming year. In particular, I wanted to commend the work of the Governor's Membership Engagement and Representation Committee, which is ordinarily led by Ranjip, and I think David was in the chair at the last meeting. So see appended to the report a number of the key actions and achievements that governors have made over the year, which are really pleasing actually to read through. In addition, we've got a couple of case studies actually in the main body of the report. I've already alluded to one concerning the workshop that we recently held with KGH governors. But also to call out Pat's involvement in the Together Against Racism workshop, which again is positive to see governors getting involved in some of the key things that we're doing, not just across the trust, but across the group. So in particular, I'd like to draw your attention to the bottom of page 2 of the report, where you'll see then the membership committee is setting out some priorities for the coming couple of years, and equally reflecting on some of the lessons learned, some of the actions required to deliver on those priorities. And on those, I am seeking, on behalf of the membership group, the council's endorsement so that we can proceed in terms of that plan over the coming year. Also, I'd welcome the council's support for including some of the content of this report as part of our annual report, reflecting on governor activities over the year. And then just a final reminder before I hand back to Krishni to take any comments or questions, or indeed it may be that David or any of the other governors from the membership committee may wish to add to my comments on the work of the group. I just also wanted to encourage governors that haven't yet had an opportunity to do so, just to let us have some information on their pledges before the end of the year, so that we can incorporate any additional content into our report. Thanks very much, Krishni.
Thank you, Richard. Richard has taken us through the report and highlighted a number of areas where governors have been sort of leading some activity or participating or contributing to things that the organisation has been doing. So I wonder if we can take the opportunity, obviously we can take any questions, but I'd really welcome comments or contributions from governors who were involved in those activities. I certainly heard that David had been had led the representation committee, but I'm not sure whether David is with us today. I think he might be, but I'm not sure. And also Pat, if she wants to comment on the... Oh, David, there you are, waving at me. I don't know whether you wanted to comment, David. It might be useful to hear from you if you'd like to mention anything from your discussions at the committee.
Thanks, Krishni. There's a lot of people on the screen, so not easy to see everybody. Yeah, I think we had a good conversation, and we came out with those recommendations, and it was felt that it was helpful to separate representation and engagement as two distinct and separate activities, obviously related. And it's all a part of how do governors engage more effectively with their constituencies, and what does that involve, particularly bearing in mind the briefing on CQC questions when governors might be asked specific questions about that. So it was a very constructive discussion, and there's a work plan there that needs to be worked out. I think I have to say for myself that reflecting on the amount of work that's needed in this area, it was in a way a reason why I said I wasn't going to stand again, because I think to do justice to that engagement is going to require some effort. And I think it's something the governors will need to engage with over the next year. But we had a good grounded discussion in taking the ideas forward. If there may be other colleagues, I was just chairing it as interim. Other colleagues may wish to comment. Krishni, thank you.
Thank you, David. No, that's really helpful, and I think it's I think the recommendations from the group are really should help to clarify things, I think, and very clearly set out the programme of work. I can see that Joanne also wanted to comment, and I don't know if Joanne was part of that conversation, but I also wanted to bring Joanne in. Joanne, whilst you've got the floor, you might want to comment on that, but I know that you also observed the board meeting, and I thought it might be helpful if you take the opportunity to comment on that as well. So bring you in on both of those, if that's okay.
Yeah, thank you. I think just to share about the meeting that we've just been in, it was useful to be able to give the evidence of what we've been achieving as a group. So, you know, moving from COVID, where we couldn't meet face to face, to doing key pieces of work such as, you know, the standards group, to also highlight that there have been changes. So Richard's appointment as Director of Corporate Governance has made a big change, working together with yourself, Krishni, and the fact that, you know, we all felt the feedback from the group was we all felt that when we say things, people listen and they act on that. So, you know, I think she went away with a very positive response. And as with everything, you know, there are reflections about, you know, what's strong and what's weaker and what can we do going forward. So we all felt it was a really fair opportunity to share back, you know, the really positive things. She got strong messages that we're working with you. We all enjoy working with you, and that's got to be good, hasn't it? So just coming back to the board meeting, I just felt that in the presentations from the NEDs, the issues that were selected and fed back on, again, really did give us assurance. And through my journey as a staff governor, you know, that's what I've been learning about since I came in, about how this mechanism works. So I just wanted to feedback positively about that I could, you know, observe that board meeting, having been in the post from when I joined, which was about August 2021, and understand the whole mechanism, because it takes some time to understand the whole mechanism as a governor, to understand how it works, what it's all about. And I just wanted to feed that back, and again in a really positive way. So thank you.
Thank you very much, Joanne. And I know you did sort of feedback quite promptly after observing the board meeting as well, and it's really helpful that you did that. And hopefully, it sounds like it proved to be a really good experience for you. So thank you. And obviously, Joanne's referring also to the earlier workshop with the Deloitte well-led assessor, and just to remind colleagues that the workshop normally is our development session that we do with governors more informally, but we turned it over to the Deloitte team for the part of the well-led review, and it's useful, Joanne, to get your reflections on how that conversation went. So thank you for sharing that with us as well. So are there any, I don't know if Pat's on the call, and I don't know if Pat would, if she is, I think she is, wanted to comment at all on the Together Against Racism event that I know Pat represented as sort of the governors on. Are you there, Pat?
I am, yes, thanks. It was, for me, it was really quite, great to see an environment where people felt very comfortable and safe to be able to discuss things very openly. I haven't seen that in a long while. So I think that's just a credit to yourselves in terms of, you know, how staff feel being well managed and being, you know, afforded space to be able to say what they feel. It was very positive, I think, even though the subject can be very sensitive. I thought the staff and everybody that was there came away very positive, actually. And it was quite nice from my point of view to actually interact with the staff on the ground, sort of get their perspective and them know who I am as well. It was quite interesting for me as well, because what I was able to do is then take that away to my sort of constituents, if you like, where I could sort of talk about what I had been doing and sort of update them. So for me, I have to say, it's one of the few very positive sort of workshops that I've been in. So it was great to see. It really was from my.
Great. Thank you, Pat. That's really helpful, and glad to get your feedback. I know there was something in it about in the report, but always nice to hear from governors personally about things that you've been involved in. And clearly, I mean, although, you know, there's some positive steps that we've taken, you know, part of the workshop was recognizing the sort of significant work that's still there for us to do in terms of taking that forward in the way that was described in the report, sort of several different work streams. But really helpful to see so many people engaged in that, I think. So so thank you to Pat for representing the governors in that workshop setting. And as Pat said, there were lots of different people involved in that conversation. So really good session. So unless there are any further questions or comments on Richard's report, just a summary really of the decision that's required from you. If you look to the bottom of paper D, the council is asked to obviously receive the report and note progress, asked to endorse the membership and engagement and representation committees activity and the sort of priorities really that have been identified, which will then be taken forward by the committee. And governors are also reminded to use the feedback form to submit evidence of pledges completed. So is everyone, the particular endorsement required, I think, is on the priorities. So is everyone content to do that? And I can see some nods, so I'll take that as a yes. But as David said, I think, you know, that still highlights a level of work required, but that's a positive then set of things for us to focus on going forward. So thank you very much for everybody who's contributed to that. Okay, so Richard, unless there's anything else that we want to cover off on that section, we move on to our next session, which is on strategy and assurance. And we've got an additional item on that today, which will come to after the Chair and Chief Executive reports, which is a digital update, which I think colleagues had asked for previously some time ago. So we wanted to make sure we offered you that opportunity to hear about that. And then we've got an item on where our non-executive directors will provide some insight and assurance around our patient experience and feedback system and the process for getting that and the feedback itself. So so those are three items we're going to come to. So starting with the reports of the Chair and Chief Executive, the two papers from our last board meeting from myself as Chair and Angela as Chief Executive are available for you to review. We will just take those as read, but just to signal that obviously if you would like to ask any questions about any of the content in those reports, you're most welcome to do that and we can come back to that. So ponder on that for a moment. In the meantime, I'm just going to hand over to Dave to just really bring to life anything that's on the top of his agenda as Deputy Chief Executive and here representing Angela as well. And then, as I say, we'll throw it open for questions. So Dave, over to you.
Thanks, Krishni, and hello colleagues, and welcome to spring. Finally, it feels it has arrived today, at least in Kettering. So I just want to draw a few things. One is just related to planning. So give a bit of an update at previous council on this. So we would ordinarily expect guidance for 24-25 planning in December. We still haven't received it, which is an indication, I think, of how pressured some of the political financial interfaces are in Whitehall in relation to that. Nonetheless, we are continuing to plan internally. We're on target. We'll be taking a set of our plans, both the Digby Q plan and the operational delivery plan, through governance over the next few months. So it will come through Council of Governors in due course. So just to highlight that for people. The finances remain stretched across the system, and this week has seen a number of escalated meetings with partners to try and understand our financial position going into next year. And it's fair to say that remains challenging, but we will provide updates further when we've got a bit more information, certainly from the planning guidance. The other thing just to flag is our 0 to 19 and CYP services generally. So we had a recent SEND inspection across partnership in the north, and we are aware that our local authorities are looking to recommission the service model for 0 to 19 from 24-25 onwards. So we will obviously be a willing participant in that. We're currently the primary provider, but it does present obviously challenges for us as a team working through that next year with two, potentially large procurements, but also the outcomes from SEND do require a different partnership approach. So we welcome that, and we welcome the new renewed emphasis and focus on children and young people services more generally across the partnership. It's very welcome from our perspective. And then two final things to finish on. One, just to celebrate, we talk about an integrated care system increasingly, but Turn Furlong, our rehab independence beds, turns a year old. As it's had its first birthday. So I take some succor from that we are, even in difficult times, continuing to drive integration and providing a model of integrated care for our population, and seeking to go further. So that's a welcome milestone, and congratulations to the team and everyone involved in delivering that. And then finally, our staff survey results came through. These are a major set of metrics for us as a trust. We take them deeply seriously. We've had our highest response rate ever, with 60% of the organisation responding. And that's really important for a few reasons. One is it obviously makes the data much more empirical, because we're getting a wider set of our staff groups responding, but also the detail is much richer, and it gives us some things to focus on over next year. There's some really good things in there, and we're in the top 10 places to work in mental health community trusts. So again, that's really positive for particularly in areas where workforce is challenged. The staff survey, and a positive staff survey, is really important. It was certainly one of the documents I read deeply before I joined, or to consider joining the trust, because I think it really is a temperature, a barometer of the trust, its culture and its values. So that's good news and really welcomed, and we'll bring more on that back through once we've digested it in due course. Thanks, Christian, and of course, happy to take questions.
Thank you, Dave. And I can see David would like to ask a question. David, please come in.
Thanks. Just a comment more than a question, but the results of the staff survey are consistent with other evidence, which it wasn't just one survey. And as a governor, I'd want to acknowledge what that actually means. This is a substantial long-term approach which has been delivered by a management team which feels to me to be pursuing a consistent line, which is immensely to be welcomed. The integration of the approach to the service users and patients, and having the same approach to the staff. In other words, how we treat people wherever they are, whether they're staff or people, are based on humanitarian values. And that is so welcome and so important, and says so much about how the trust is working. And it's sad that it isn't seen more across the NHS, but also in other places where people could learn from what's happening. So I take immense comfort from that, and would congratulate the team on delivering it all the way through. It's a really difficult thing to do, and to have done it so consistently over such a time needs to be noted and celebrated. It doesn't mean that there are not things to improve, of course, but it is really helpful. I'm next week involved in the Commonwealth Advisory Committee on Health, so I've been taking soundings and hearing information from around the world on what's happening in health services. And it's quite clear that in health and social services, workforce pressures are a global crisis. We are seeing just a part of it, and it's going to be a real challenge, recruitment and support. So it's good to know that the trust has got a good approach to supporting diaspora workers, and it's good that next week some of the team from NHFT is presenting in a conference I'm involved with around that issue, and it was good to meet them and to talk with them about that and to hear what is being done. And again, that is a very significant achievement against very difficult background, so that's very much to be welcome. And finally, on climate change, it's clear that this is a coming global pressure. It will have lots of impacts, not least on the migration of people, which is such a contentious issue within our country, but it's going to be a growing issue across the world. So it's good to know that we are engaged with the consequences of that and thinking about how to manage it, not only migration, but also the changing environment and changing climate patterns on people's health in our immediate locality. So all of those are forward-looking and good to hear. And thanks, David, and congratulations to the staff team for delivering on all of that. Very significant.
Thank you, David. That very welcome contribution. Thank you. And so important, the points that you've made. And certainly, you know, I think it's really important to say it has been a consistent sort of focus of the trust to really look at how we support staff and really you know, create the kind of environment in which staff can thrive. Not to say we've got all of that perfectly right, as you rightly said, David, but it remains focused. And I think important to say that, you know, the evidence from Michael West and others suggests that, you know, shows that actually there's a correlation between staff engagement and patient care, and ultimately that seems to me a fairly sort of straightforward then reason why it's right to do it on all fronts, really. So thank you. And just to say that the staff survey results will be discussed at our public board, which is going to be coming up obviously shortly. So any governors who would like to observe that section, you know, welcome to watch that live or indeed watch it subsequently. So we'll have no doubt you know, a good debate on that. And I'm sure I'll sort of look at Richard here, but I think we would expect to bring a little bit more of sort of our understanding of those results and our analysis of that back to the council in due course. So it will be on our work plan. So this won't be the final opportunity for governors to understand a bit more about that, because for all the reasons that Dave and David said, it's a very important milestone in the year for us when we get our staff survey results and look at how what we've done well. So thank you. Okay, Matt, I think Councillor Golby wanted to come in.
Hi, Christian. Thank you. I just wanted to make a couple of comments and echo the positive points Dave made there about Turn Furlong, which remains a really good piece of partnership work certainly from the LA side and what we've done with NHFT in a very challenging time for the system. And Dave also mentioned the 0 to 19 contract, which sits within my portfolio at West Northampton Council. And as you say, Dave, I think it's a good opportunity to refocus and reframe to get obviously the best possible outcomes we can for that age group, which again has got some very big challenges. And also, you mentioned the SEND inspection in the north of the county. We've actually got one in the south now, and I'm sure you've picked in the west. Sorry, I'm sure you've picked that up, which again puts a big burden on partners like yourselves and staff that will have to sit and go through the same thing they've already been through in the north once. So just to try and show a bit of empathy with all of your staff, and wish them well, because again we know there's some challenges in that area, and it's difficult to put people through things twice, and I think that point has been made to Ofsted. Thank you.
Thanks, Matt. They will appreciate that much. Thank you.
Thank you, Matt. And just as a quick reminder, in case colleagues are trying to remember what the RIBU or Recovering Independence Bed Unit is, it's a joint. I think it's safe to say, or fair to say, it's a jointly staffed between local authority social care staff and ourselves. And so, and I don't know, David or Dave, whether there's another one like that in existence. It's not commonplace, is it? And as far as I know, that approach.
Yeah, I mean, we haven't done a kind of a systematic trawl. I mean, I think it's fair to say it does feel like we broke new ground with it, and obviously there are different models emerging now, Northumbria, recruiting care staff, etc. But for us, it's important because the local authority, our partner estate in that space, is really high quality. So it gives us a double impact in the sense of integrated care with health and social care together, and a high quality functional building to do that in, which is a great use of one public estate, really. Yeah, and ultimately, patients or service users supported by, but holistically, really, with in terms of needs. So really important, and a great development, and something we can be proud of, and I think to build on for future integration opportunities. Okay, we've got a couple more comments and questions. So Joe Lancaster.
Yes, thank you, Krishni. Dave was very modest, I think, in some of the points on the staff survey result, and I just wanted to reinforce some of David's comments, because 60% turnout is extraordinary, and the confidence with which staff feel able to address comments is fundamentally important to that process, but also the culture of continuous improvement, wanting to be the best that they can be. So I think, David, I agree completely with the points you were making. I think the other strand, Krishni, which is really important for governors to appreciate, is that the staff survey results are done consistently year on year and gathered, and it allows us to compare ourselves with others, which is great, but it's also really good for self-reflection, because we can compare ourselves once we do interventions, and once training is rolled out, things like that, we're able to see the impact of those types of interventions and investment. So from a governor's point of view, there is the double benefit of both an inward and an outward comparison.
Thank you, Joe. Thank you. Really helpful additional reflection on that. Richard, please. Richard Amponza.
Thank you, Krishni. So just following on from Joanne's comments, obviously my work involves gathering a lot of data, so I was particularly pleased to see the increase in terms of staff responses. But just to make it even more relevant, our staff engagement lead has been working with service leads and operational leads just to look at the data and to interpret and analyze in terms of what does it mean for the areas that we're talking about, so that we can use that data to improve staff experience, and therefore by extension the experience of our services and care. So I think, yeah, there's beyond just collecting the data. We're asking the what if question, and Gabby is working very closely with our operational and service leads to make sure that the data is used to improve the experience of our colleagues, and therefore the experience of our services and care as well. So it's really gratifying to know that.
Thank you, Richard. Thanks very much. Really, all very helpful contributions, I think, and hopefully governors will feel sort of illuminating in terms of the approach to the staff survey. But as I've said, we will come back to this because I think it's an important area for colleagues on the council to understand. And just to pick up, Joanne Durham, Paul Smith has mentioned the work on wellbeing being very evident, and commenting on the thank you card that was sent to every member of staff, which I think was last year, if I remember correctly. There was a thank you card to every member of staff with links on how staff can access resources on wellbeing, and that I think went down well. And there's also some opportunities for staff to recover and R&R, I think we call it, don't we, Dave? Which we've encouraged staff to take part in as well, because obviously one part of the staff survey is the wellbeing aspect, which is always looked at. It's broken down in terms of people promise. So all these things, as I say, we will come back to, but it was important. It is important news and very significant moment as at this time of year, because we always know we can anticipate getting our staff survey results and take action on them, which is the most important thing. So thanks everyone. Thank you, Dave. Anything finally you want to add yourself, Dave, before we close that item?
No, really helpful comments, and as you say, Krishna, it'd be great to kind of look at the detailed staff survey and triangulate inputs and outputs to some of the results we're seeing, because there's work to do and there's things to be proud of too. So I look forward to that.
Brilliant, thank you. And I take it there are no questions on anything in either report, but if there is, please don't hesitate to raise your hand, because we are reasonably comfortable for time at the moment, although I might regret saying that, because it often goes the other way on a subsequent item. So do please come in or raise your hand, or a note in chat if you'd like to, and I'll raise the point for you. Okay, we'll move on then to our next item, which is our digital update. So we are welcoming Gareth Jones and Julie Mansfield. Now, I do want to just check that Julie and Gareth are here. Yes, they appeared on screen just helpfully at that moment in time. I think they're both in the same room from what I can see. I'll let them introduce themselves, but as I explained at the beginning, this is a digital update, and it's giving you a bit of an update on something we call the Northamptonshire Care Record, and also the analytics and reporting platform that we're going to be using across Northamptonshire. Gareth and Julie, I'm just going to remind you that governors won't necessarily be familiar with a lot of technical terms, so you're going to need to explain anything carefully, but we'll also, if there's anything we feel we need to clarify, we'll try and use chat as well. But over to you, Gareth, to kick it off.
Thank you, Krishna. So hopefully you can hear us well. We're in a room we've just set up, so hopefully you can. So thank you. So I'm Gareth Jones. I'm the Trust Chief Information Officer and Director for Digital. I'll let Julie introduce herself.
And I'm Julie Mansfield. I'm one of the Assistant Directors for Digital, particularly with responsibility for the clinical system side of the Directorate.
So we're going to try and share the presentation that we've submitted. Hopefully technology doesn't fail us, because that'd be quite embarrassing. Bear with us 1 second. Hopefully you can all see that. Wonderful. So as Krishna mentioned, we're coming along today just to kind of give an update on where we are on some of the system technologies that we've been putting in place for the last few years. Things such as the Northamptonshire Shared Care Record, the analytics reporting platform, which we will explain in a little bit more detail. Hopefully everyone will get it later on. And some of the other things that are going on around the county as well, around digital and health and social care. So what we've got here is the joint forward plan. So it's kind of based on our strategy that we've got for the system, based on the ICS aims as well. So it's about obviously improve outcomes for population health and healthcare, tackle inequalities in outcomes, experience and access, enhance productivity and value for money, and help the NHS support broader social and economic development. Obviously, there's a number of national priorities there, and also a number of local priorities that we've got. And digital is one of the supporting work streams under all of that, along with data as well, to help us as a system deliver those local priorities that help us deliver the national priorities. So moving on. So in terms of the context and ambition for digital, so obviously one of the main aims we've had is we're all in different maturity places as a system. So NHFT is considered one of the more digitally mature trusts in the country, based on NHFT standards. Our acute trusts aren't quite yet in the same place. We've obviously had our electronic patient record for about 15 years. They're just in the early starting phases of putting theirs, curing theirs, and putting theirs in place. So what we want to do, what we recognise is that patients often turn up to different settings, and they ask the same questions over and over again. I'm sure we're all familiar with that. You'll be asked all sorts of information of what type of medicines you're on, what type of allergies you have, things like that when you turn up to A&E or turn up into your GP setting and other places. So part of this is taking all that electronic data that we hold in different places and trying to bring it together into one place where both the patients can see the clinical and health data that's held on them, but also the clinicians can see that data and make more informed decisions for care for the people to hopefully keep them in the best place possible, whether that's at home or in a care home or wherever that would be. So in terms of what we need for success, so obviously we've been quite successful at getting funding into our system over the last 4 years. I don't know the exact figure, but it is many millions of pounds we've got in. Either it's gone into the acutes to help them on their digital journey, or it's come to us through what's called the frontline digitisation aims, where it means that we've had about 5 million over the last 3 years, including next year, to help us continue to develop our EPR and applications that will help people manage their conditions better themselves and from different settings. So the kind of the main aims, ambitions we want to deliver is, I said, the Northamptonshire Care Record, which Julie will elaborate on more in a minute. Northamptonshire Analytics Reporting Programme. Obviously, the NHS app. I mean, I think about 75% of people now have the NHS app on their phones. COVID was a great motivator for getting the NHS app installed. But obviously, as an NHS, we're driving more and more applications through that. So one of the aims that we've got as a system is start putting our clinical systems data into the NHS app so that patients can see their appointments, can change their appointments, can contact people, see their health information there, see their last GP appointments, last appointments, whether it's in a mental health setting or community setting or within an acute setting. So we have one digital front door that everyone knows about and can access. And then also what we've got is our Digital Skills Academy and accreditation, and that's mostly to help raise the digital capabilities of our workforce, because obviously we're implementing lots of new technologies all the time that either we're choosing, one that NHS England are choosing on our behalf. We're aware that a lot of our workforce isn't necessarily at the same level of digital awareness and capability. So some of this is about looking at how do we address those digital capability skills. So our aim is by the end of 24-25 that we'll start having a good central place for all our high quality data. Our digital technology will be there, available and accurate. So we'll have our data joined up and we'll have the right tools to enable people to make the right decisions in the right places. And hopefully we'll start looking to combine health and care data as well. So it's not just the NHS data that's held, but also looking at working in social care to see if we can get their data in as well. So we can have a complete view of somebody's health and care pathway through our digital technologies. And also what we're saying about we'll have the digital insights into that as well, because we've got such rich data and we've been through the IG process over a number of months and years to make sure how we use it is correct and accurate. Is to have that data there that we do our population health and demographic data, and understanding where we have areas of deprivation and how we focus our resources into the right areas and where we can take interventions and where we should be making interventions. Moving on, this was last year's programme plan, just so you can see all the things that were going on, all the activities been happening. So these are around, first one is data sources for the NCR. so Northamptonshire Care Record. So that was things like we spent a lot of time getting all of NHFT's data in there. So there's about 20 years of NHFT data now flowing into that central system. There's all the GP data is now flowing into that central system. And we have some data coming from the acutes also flowing into that system. And where we've struggled a bit more is in those areas getting data 111 to be able to access that data. Our remote monitoring tool, which is called Docabo, to access the data and other things, and also working with the two councils on their data and helping get their data into that system. But the NCR is live. As I said, Julie will give more information on that in a minute. And NHFT and our acute partners and GPs are now all actively using it. And I think about 50,000 users, but that's in, Julie will go through that in more data. And then these are the other programs. So we've also got there things such as the Respect Form. We've got My Care Northants, which is a patient portal project. iCare electronic referral system called ERS, and also a system called ViewIt, which is another analytics platform that gives us national demographic information on health. So how many people are waiting for care packages and things like that we can overlay within our systems. And then looking forward, these are the things that are happening this year. So obviously we're continuing rolling out Northamptonshire Care Record data, getting more data in there. We're talking to St Andrews Healthcare about perhaps getting their system data into that central system and giving them access to it. Obviously continuing working with the councils, also working with the ambulance service and getting medicines data in there as well. And we'll continue to roll out the shared care record to other organisations. And obviously then carrying on with those other projects that I mentioned as well, My Care Northants, adult social care digital transformation, stuff we're supporting with Pathfinder project and other things. And now I'll pass over to Julie to give us more information on NCR and hopefully remove some of the myth about what it actually is.
Julie, before you come in, can I just pause us a moment to see whether we can get the slides on full screen, Gareth? Because although we can see them, they are actually they're not full screen on slideshow. So I don't know whether it might help people. That's it, brilliant. So we've got it there. That's super. And is there anything before Julie comes in that anything, I know she's going to talk in a bit more detail, but anything people perhaps just want to clarify before we hand over to Julie? Is everyone okay with what we've covered so far? And it's given you a broad understanding.
Just to feedback, Gareth, as a user, as a staff member and dealing with patients, it's really great to be able to go into and use this, and we are finding interesting bits of data all the time. So thank you.
Brilliant, thank you, Joanne. There's some live feedback for you, Gareth and Julie. But hand over to Julie now. Thank you, Gareth.
Thank you, and thank you, Joanne. That's really good to hear, because obviously, as Gareth has said, this is a national requirement that we have a shared care record. But we're not doing it because of that. We're doing that, because we do want to drive the sort of quality, safety, efficiency, of things from both the patient and the staff perspective. So it's good to hear that it's having that impact, and it's feedback we're receiving from others as well. So Northamptonshire Care Record, what you can see on the right hand side of the screen is a view of what that record looks like when you go into it. Most of us as organisations are lucky enough that we can go on through what's called single sign-on. So if I was looking after you or Gareth in Northamptonshire, I'd go into Gareth's System 1 record, and then this is a tab that I can click on to take me out to this. So it's very easy, quick, reduces the risk involved maybe searching for somebody else's record. So it's intuitive to use. Also intuitive to use, I hope you'll agree, Joanne, in the sense if you've used it, in the sense that you have the tabs across the top. You can see those blue icons, and you may be able to make out one of those if you want to click on the community record, if you want to click on GP letters, if you want to go and do on medication, or you can do an all view. So at the moment, this is fed by all of the information that 3 primary contributors can add to it. So that's your GP record, whether it be an EMIS record or a System 1 record, which are our 2 GP systems in the county, whether you're a patient of one of the acute trusts or whether you're a patient of NHFT. As Gareth has mentioned, earlier as well, there is a difference in the richness of the data that is shared based on the level of maturity of those organisations' clinical records. So obviously, as Gareth has mentioned, NHFT and GPs are lucky that we've had an electronic patient record for some years now. KGH have got a limited optimising record at the moment. NGH at the very beginning of their journey, they have a PAS system at the moment, which basically means that they can share their activities, admissions, discharge and transfer data at the moment, and that will grow over time, as it will from all of us. So what we've gone live with basically is a piece of work that's taken about 2 years to match the data from those various systems to make sure that once it's presented in the Northamptonshire Care Record, it retains its meaning and context from all of our various systems. And that's our baseline starting point from which this will now grow as the maturity of our systems grow, as the partners who can feed into it can grow, so social care records, and in terms of partners who can then benefit from the data as well. So as Gareth mentioned, the Ambulance Trust being able to see this information to inform their view on where it should go next. And I suppose linking into that where it should go next, you will have seen on the previous slide that the respect form is one of the major pieces of work that we're all trying to focus on this year, in the sense of, you know, your care wishes, end of life care wishes being rapidly available to everybody who's having to make those decisions on your behalf, or, you know, at points when you may not be able to express them. So a really critical tool. The main benefit for patients, I think we've covered already, really. Tell your story once, not have to repeat unless you need to. If you're unable to express that information for yourself, knowing that it's available there for you. And for clinicians, saving those, you know, endless telephone conversations, trying to get in touch with a GP to glean this information, particularly for A&E colleagues, saving a massive amount of traffic and delay and inefficiency between care providers at those handover points. Everybody knows what we all know at the click of a button, and can have their decisions informed for them and to inform care. I don't know if you'd like me to pause there for any questions about the NCR itself before I go on to usage.
Thanks, Julie. Yes, so that looks like there is a question, so good moment to pause. Sam, please.
Thank you. I've just got a couple of questions. So you've kind of illustrated the benefits, but with everything that has benefits, there are obviously some negative things as well. The first one is, who holds this data? Where is it actually physically held?
You can cover that one. So it has been through. So the answer is that it's held by GraphNet, so they are the supplier of the solution. Right. The data controller element is slightly different to that. But basically it has been through really rigorous IG sign-off, both by the organisations that are party to sharing the information into the NCR. So all of the organisations who shared the data have done their own due diligence and nationally required assessment of GraphNet as a provider. And we have also done that collectively as an integrated care system as well. So really tight governance over that. Okay.
So was there any consultation with the kind of end users, the patients and the population? Was there any consultation?
There was engagement rather than consultation, because this information is shared for the purposes of direct care. It's covered under the sharing agreements that we have between ourselves as organisations. So the only people who can see the NCR are those who have got a direct caring relationship with that patient, and that's the other benefit of single sign-on as well, that nobody can go into the NCR and search for anybody. You've got the audit trail behind your core clinical record that you have to bypass an alert saying, yes, I have got direct involvement with the care of this patient to proceed. And then you've got that other checkpoint when you then go through single sign-on into the NCR as well. So a really close, tight audit trail and control on who can access.
Okay. And is there the ability to restrict access for, I don't know, somebody that maybe public interest. You
There is
mentioned you're bringing in St Andrews data, and I know that there are certain people being
yes,
cared for at St Andrews that you wouldn't want information about their care going out
yeah,
beyond the direct team looking after them.
yeah.
So are
So,
those kind of controls there?
sorry, talking over you. Yeah, so all of us as patients of the NHS have the choice not to share our clinical data. That if you make that choice, there's a quite tight process to follow, because that's obviously a really significant decision to make in terms of how that might impact your care further down the line. So that process at the moment is governed by GPs. So if we had any patient who expressed a concern, who arrived at any of our organisations saying, I'm really concerned about this thing called the NCR, or indeed this thing called System 1, there is a process whereby obviously we'd seek to reassure the patient, but at that point, if they still feel they want to proceed with that not to share decision, they go to their GP will do that due diligence check with them, make sure the patient's informed of all the risk and has got capacity at that time to make that decision. And then a national code can be applied to that patient's record. And that means that that record will not be shared either to the national spine or to any other system. And there is coding to that's part of what all of the integration partners will do for any system, is exclude that code from when they pick up the records and share them on.
Okay.
Thank you, Sam. That's a really comprehensive set of questions, and hopefully Julie's given you a detailed answer. I'm conscious there's quite a few other people wanting to come in. So, Sam, if there's anything else, can you please do put it in chat, and we can
Sure.
try and sweep it up. Thank you. Melanie, please.
Hi, everyone. Yes, I was just reflecting on the fact that governors might be interested to know that I attend the Integrated Performance and Integrated Planning, and Resources Committee of the ICB, which holds the responsibility for scrutiny of the digital programme and progress. And it's normally a monthly topic. We have focused a lot of discussion in the IPRC around how to ensure that the care record is rolled out to as broad a cohort of organisations across Northamptonshire as possible, and the team have just referenced rolling it out to GPs, to potentially St Andrews, but also to third-party charity organisations. There are clearly strict protocols attached to doing that, but the record success will be most beneficial when it has the maximum amount of content within it to assist all parties involved to provide the very best care. So I just wanted to clarify that that's a real focus at the ICB across the integrated care system, to see the care record rolled out safely across all participating organisations. Thank you.
Thank you, Melanie. David, please.
Yes, Sam raised some of the questions I was going to mention, and it's good to have the feedback. Thanks on that and how seriously that is taken. I think approaches and attitudes to confidentiality and who can see and so and have access is evolving and changing, not least as people put more of their own personal information online in social media and so on. But that doesn't mean that any of the rigor of monitoring access should be reduced. Indeed, it's going to become more and more important in relation to insurance and other things. So that's really good to hear. Thank you, and please keep that up. It's got to be looked at. The second point on the other side is that I chaired a consultation meeting with partners when I was in Health Watch about 5 years ago, I suppose. And one of the main requests from that consultative meeting with the public was to have an integrated care record. And at that point, it looked almost impossible to be able to put it together. So it's really good to see the progress that has been made, and that is meeting what I think people want to see. So balancing that and the access issues is one of the big governance challenges, and it's good to see that that's being addressed in a rigorous way. Thanks very much.
Thank you, David. I'll take Carol and Robin if I can come back to you, because I'm really conscious we paused Julie in the process of her presentation. So I'll take a comment from Carol, hand back to Julie, and then we'll sweep up any final questions so we can try and cover it off. So Carol, please.
Thanks, Krishni. Thanks, Julie, for your presentation. I think everybody from a carer and a patient and a staff point of view will welcome this movement towards the Northamptonshire Care Record. I have a couple of practical questions. Does the patient see the NCR?
No, they don't. No. So at the moment, this is a tool for clinicians. There is work, however, that's going on around patient portals and patients' views of their records. Now, that's quite an interesting one to look at from an ICS perspective, because as Gareth mentioned earlier, we want the patient, us, we're all, I'm a patient of Northamptonshire, we want to be able to have quite a clear route of one front door in. So at the moment, some of us may have the app that lets us see our GP record to order our medications. In the future, we're going to have an NHFT app that lets, remote booking and the acutes, I'm sure, as well. So that's one of our challenges moving forwards, is how we create those patient portals to give the patient view of that, and also some interesting challenges around radiology and pathology that are being discussed at the moment about what is the right time for the patient to see it, and how do we make sure that a patient is supported to receive that type of news. So yeah, active piece of work going forwards, but this is the clinician tool.
Okay, the other question was also practical. Obviously, some patients will have quite a lot of patient records in different places, historical records. Will these be all uploaded onto the NCR? That could take some time in some patients' cases.
Absolutely. And what happens, so when we do a project that moves us, so NGH is going to be very close to their heart for the next year or so. So when we take an organisation that is based on paper to an electronic digital record, decisions have to be made at that point about how do we maintain the history whilst moving forwards. If you scan the history into an ongoing clinical record, you end up with an amorphous blob of information that's actually more dangerous than it's useful, because it's not accessible. The way that is usually handled is by a summary being done by your lead clinician, and that is then entered onto the clinical record going forward, so it sits where it should do. Your allergies are where your allergies should be, your diagnosis is where your diagnosis should be, and we then agree a time span when your patient record is needed to build up that electronic to be as rich as possible. So that is something that we will be aware of as new sources come on, and a clinical safety case is written for this tool every time we bring in new information, as well as the IG checks, to say, how do we make clear what is visible in here? So for NGH going forwards, we will be aware that it will be the information from when their feed went live. For us, it's our information for the last 20 odd years. For GPs, it's probably, could be lifetime of your record. So it's a managed clinical risk all the way through those phases of moving from one to the other.
Okay, thank you. And just one very quick question. I've come across the Respect form, and I understand that Northamptonshire are doing the training, and you hope to roll it out in May. Is that on track? Do you know?
I'm not 100% sure whether that's on track at the moment. That was an ambition. I think the challenge that we have is that it is such a big change in practice around the county. We need to make sure it's absolutely safe in terms of, historical versions, new versions, everybody knowing where the version is. So I know the team have got that as a target date, but it does shift to reflect that, safety element.
Because it is in use in other parts of England and Wales. So I just wondered if it was on track for May. Okay, thank you very much.
Thank you, Carol. Right, Julie, I think we're going to need to come back to you, and there's comments and things in the chat as well, but perhaps we'll pick those up at the end. but we will need to speed up a little bit because, as ever, we've now used up the time we had available, and we're running a little bit late. So back to you, and we'll try and speed it up a bit. Thank you.
Yeah, and I think that's the bulk of the sort of the bit about the NCR anyway. I think we go into utilisation figures next, do we, Gareth? Is that's what's next in the slide deck? So respect, I think, yeah, I think we've covered those bits of what's in the record. Now we've put the usage in. I think we track usage at the moment because we're aware it is such a big, we call it sort of business change when we move people from one system, introduce change into that environment. You know, if you think we're trying to reach every relevant clinician across the county, which is no mean task really. So it's both checking out our initial comms campaign, you know, have we got the message that it's out there? Is it still being used? Are people using it once and maybe think you're not going there again, in which case that's a message in itself. But just to say that we are tracking the utilisation so that we can then look at how effective that business change has been. Can we use some of the leading lights of the NCR, as it were, to lead the way for others, and so forth. So just say we're tracking it, we're monitoring it, and it's really useful information for us to then make sure that everybody can benefit who needs to. The NARP, now the NARP, so the NCR is that shared information for carers and patients to be directly involved in those care decisions, your actual care at that time. NARP is the analytical version of that. So it's taking that data in both a completely anonymised format for planning purposes, but also for those people with the access rights, such as clinicians, to be able to drill down to their caseload level. So, for example, for GP, we've got hypertension up there. For GP wanted to look at their caseload through the NCR of show me all the, you know, the hypertensive patients on my caseload receiving care across the county. They can drill down into the NCR from that point of view. So a lot of excitement and interest in that one from clinicians, particularly around safeguarding information and how we might use that to spot safeguarding issues in families, because, you know, obviously we manage the individual at the moment, but again, really tight IG controls around access to that, what it can be used on, who can access it. And it links nicely into the next slide, really, which is about the, oh, sorry, that's just an example of how it can be used. I think, does that one show depression? But really, a dementia. So it's really an analytical tool that feeds from the NCR so that we can do that population health planning and that individual caseload management at clinician level. And the next slide, Gareth, more examples of what it looks like.
So it kind of shows we're pulling information from the whole population.
Yeah.
And then drilling down for dementia, so we can start drilling down to the areas there that on the heat map that are showing the areas where dementia seems to be quite high in those age ranges that we've got on the left.
I think what's new really is GPs have been constantly doing this, like photo QOF points and payments and, you know, medical registers of patients with particular conditions. This allows us to do it on a much bigger scale, but still focusing down within our county. And the Digital Skills Academy just sort of links into that part really. There's a thing called the Apprenticeship Levy, which is a pot of money. The ICS group that together and have partnered with a third party to take on some apprenticeship level training, which is really focused on digital literacy at the moment. So I think, you know, as clinicians, we're used to using the clinical record, but when, you know, you give us the NARP and start saying, you know, now analyse your cohorts and your caseloads, it's not always a skill set that we've been trained in to use. So the first part of the Digital Skills Academy is to help. It ranges from, you know, our developers who use data, analyse data all the time, providing a career path for them, but also for clinicians who are sort of entering into that territory for the first time. So that's just launched with its first cohort of patients, and as you can see there, we're having feedback at the moment, looking to do a next cohort in September, but also then broaden out more into digital skills more broadly. And what we're therefore building is a sort of spider web model of within our own organisations having a digital skills academy that deals with specific local needs, but all linking into this ICN level academy that can handle the core, the shared development that's needed.
And then kind of our final slide, which is a summary slide. So it's got a lot of information on it. As Richard said, he's going to share these later. So we're happy that people come back to us later on with any questions you might have as well, if anything comes through afterwards. But it kind of goes through the key achievements there that we've managed to do over the last year, which we've kind of gone through at the moment. We think we've saved over 300 days saved of clinical time so far by using the NCR. Obviously, that number, it hasn't been live. It's live about 6 months now, the NCR.
Yeah.
So, and that's just in the first 6 months. So hopefully, not only will it save people time, it will give richer, more complete data to make better decisions, clinical decisions. Obviously, we've also got the NCR, the NARC, which you've seen, which we're not live with yet, but we'll be live with it soon. And it's really starting to make, to show us some trends and analysis that we weren't aware of before, but hopefully will then start to inform some of the work that we do in future, especially in terms of interventions and focusing in certain areas. And then, as we say, the single front door. So as you said, at the moment, we're working on our patient portals, as most of the NHS is doing. Recognise it as a priority for NHS England to do that. Our problem at the moment, we will have very different clinical systems that have their own different patient portals. So one of our aim is, rather than proliferate people with different patient portals, but how do we get them linked into the single NHS app? Said earlier, most people actually now have on their phone or can access to on their computers. So making sure it's a single front door, so people aren't jumping between different health organisations to see things. And obviously then the disclosure code, which you mentioned. So thank you very much. I think we'll end there.
Brilliant.
Any further questions?
Gareth and Julie, thank you so much. We've literally exhausted our time now, and we've got another item to cover, so I'm really conscious we're going to need to move on. But hopefully that's given colleagues a really helpful insight into some of the work that's being undertaken and the outcomes of that work so far. I mean, the thing that, you know, I think is really important and lots of colleagues have highlighted is there's a real balance to be had, isn't it? You know, at the end of the day, we know that one of the biggest pieces of feedback patients give us is that they want to only tell their story once, and they find it really frustrating when they have to go to different providers and tell their story again and again. So actually part of the care record approach is the shared care record approach is obviously about easing that, but that has to be balanced, as I think David and Robin and other colleagues and Sam raised a lot of questions about this, about, you know, protecting the data, making sure it's managed appropriately, safeguarding it, and make sure it's being used for all the right reasons. And Scott helpfully shared some principles that have been pretty long standing in the NHS about the use of data, the Caldecott principles. And we do have the Caldecott Guardian in every trust. And I believe in our case it's Itai. Dave will shake his head if it's not, or nod his head as he is. So Itai Martin BK, who's our medical director, who's our Caldecott Guardian. So that's a very special role. And of course, everybody, you know, we take, you know, just a reminder as well that information governance is so important and strict within the NHS that it's one of the few areas where all of us have to do our training on information governance every year without fail and report on that. So it's a really important topic. And as Richard said, you know, something we might be able to come back to in terms of covering you know, giving another opportunity for governors to hear more about this and talk about this. But thank you so much, Gareth and Julie. Really good, really insightful, and the level of engagement and interest in the topic suggests it was really timely for us to put us on. So lovely to see you both, and thank you so much for your contribution. Right, we move on now to our final topic of the session, and it's a NED assurance topic, and we this time I think picked patient experience, partly because it's linked to a new system, but it's obviously a very important part of how we seek assurance as board colleagues. So I'm delighted to hand over to Robin and Julia, who will jointly take us through this. So over to you both.
Hi all. We haven't got a lot of time on this, so we're going to have to move at some sort of pace in covering some of this. And it is another discussion of data to some degree, but I'm not going to go into the micro detail of all the issues about IG and all those other things that we've covered so clearly in the other session. And I'm going to talk more about the way that we use and the trust uses patient experience data as part of the overall approach to managing and improving quality within the trust. And it comes back down to exactly what Dave was saying when he was talking about the staff data. This is about an expression of culture. This is about an organisation that really cares about what patients think about the quality of service that they're getting. And the real effort and investment and time that's put into trying to find and obtain good patient data and to use it is part of the overall approach of improving quality within the trust. And so patient experience data is one of the bedrocks of that range of data. You know, there's stuff about outcomes, there's stuff about training and level of staffing on wards, there's all the patient safety data and everything else. And you put it all together and you have an overall picture of quality. And within that, patient experience is crucial. So can I have the next slide then, Tracy? So I'm hearing a lot of feedback on the call on this. I don't know if anybody else is hearing that as well. I'm hearing a lot of noise. I hope that it isn't stopping people hearing this properly. But what we're primarily talking about here today is IQVIA, our new system for obtaining data from patients about their experience as opposed to their outcomes, about how they feel about the service that they receive. And it is not the only source of patient data. There's other material that comes from PALS and complaints and Healthwatch and NHS Choices and CQC. There's other routes by which patients communicate information about their experience to us. But IQVIA is our bespoke platform, a new platform for obtaining that in a far more systematic way. And as it says on this slide, it's an emphasis on culture and openness, asking how is it for you? And IQVIA is ultimately just another software platform, but it's been chosen and implemented to achieve greater impact in terms of channeling patient views. So can we move on, please, Tracy? Next slide. So I'm not going to go through all the background about the process of choosing IQVIA as an alternative system. The rationale, though, was very strongly that the old system was very paper-based and didn't give us the volume of records that previously we've had. So it's nothing like 60% as we get back from staff. It's a very much lower percentage, sadly, than that. And that was partly because it was very paper-based and very mechanical kind of system. And the new system, IQVIA, because it uses things like QR codes to enable feedback to come directly from patients in situ, has far more potential to dramatically increase the volume of return that we get from the very low percentages that we had to a much larger percentage. We're never going to get 60%, I doubt, from patients, but we can really improve that using this new system. And this is how it works. The information comes up directly, sometimes in real time, or will do, to managers, so they can see all this feedback and they can use it with their teams to drive quality improvements within service delivery in a much more rapid way. So this is very much co-production. This is staff, patients, service users and carers all working together. And the technical potential of the IQVIA system means that it can also analyze material in a far more clear and informative way to enable managers at the immediate service level and above that to really use this to improve quality of care. And as the slide says, this is very much about leadership. This is about clinical leadership, but this is also about management leadership, really trying to embed experience into the way that we do business. Go to the next slide, please, Tracy. So this is how it works. All these things come up. This data is fed up through a whole range of channels. At the immediate team level, it's looked at and triangulated so it can be seen as for what it tells us about the way the services are organised. But it's also then triangulated at the corporate level alongside that to drive improvement. It can be escalated through weekly early warning systems. It is reported up through patient experience groups, which is all part of our overall quality framework, which no doubt we will be back to tell you about at another later point. And the kind of key questions it tells staff: how do people really feel? What works well? What changes are you making to improve this service? Can I have the next slide, please? But what I want to get over to governors is how this isn't just dealt with within the trust's internal management in terms of the various committees and systems where data is looked at, because there are level 2 committees such as Quality Forum and Complaints that look at this data. But it also then comes up directly to the Quality and Safety Committee, and we really look at this in more detail again through there. And then it is some of the data goes up then through Dave Mayer's integrated organisational report, which goes through all committees. And we had a little discussion about it last week at the Performance Committee, for example, where we looked at some of the little teething problems that we're getting with the data at the moment, because it is still in the process of being fully integrated into our systems. But then it comes up right to board, because Dave's report goes to board and we take it through Quality and Safety to board. So this is absolutely part of the assurance that NEDs get about the quality of care and the quality of service. And it is there used all the way through to drive improvement right up to board level. And just to give an example of that, I think Julie is going to tell us a little bit about how it's used as part of the Complaints Committee.
Thanks, Robin. So very, very briefly, I just wanted to bring to life the breadth of areas covered at the Complaints Committee, just because it absolutely underpins everything Robin's just said. So thanks, Robin, for that. So we do focus on data, obviously. Response times to complaints, they are improving, but not where we'd want to be completely. We do have resourcing challenges within the teams, but actually we do monitor that and we do look at how we can help. Themes are really important. So the theme of learning across all patient feedback and how Robin's described how we use that, that's the whole point of this. And the themes that come up most frequently across complaints, well, you won't be surprised, that's around waiting times and access to our services, communication, sometimes clinical issues. So for example, there've been a number of complaints about our clinical care of people that have wounds, and the district nursing team came to the last Complaints Committee and talked through some of the themes, some of the work that they're doing to improve the management, prevention and overall sort of oversight of wound care. We have lots of different partners join us at that session. So Health Watch, we have service users, all bringing really different perspectives and really very valuable experience. And we have a peer reviewer group who look at some of the responses to our complaints that we've formulated, anonymised, and then look at it from a sort of a clear language point of view and a fairness point of view, and have we actually addressed the concern from the complainant. Other bits, we're planning a self-assessment against the Parliamentary Health Services Ombudsman standards. So again, that tells me from an insurance point of view as a NED that actually we're looking at important standards nationally, and we're looking at where we are, and there's some training will flow from that once we've done the self-assessment. So lastly, I just want to leave you with two key messages. One is that learning comes through all of this. It's always at the forefront of everything that's talked about in the Complaints Committee. And most importantly, some of the changes that some of our services have made on the back of complaints. One really quick example, in one of our inpatient units recently, a relative very, very rightly had complained about the process for giving relatives back the laundry, the clothing from their loved ones, particularly when they're soiled. That's not a very pleasant experience. And the ward changed the colour system for bags to take laundry home so that it makes it much clearer for relatives actually what they're dealing with. That's had a huge impact. The feedback's been incredible from that, and I think they're looking to roll that out in a number of other areas. So one small thing, one complaint, but actually really important. And that's the sort of change I think that happens across all levels in the organisation, and why we seek feedback all the time. So that's just a little flavour of the assurance we get through that committee, and then it feeds up. So thanks, Robin, for that.
Thanks, Tracy. You can take the slides down now.
Great, thank you. Robin, I think you weren't coming back in, were you? So happy to pause there and invite any questions.
Krishni, can I just give a one-liner in relation to the points that were made about IG before? People will be aware, of course, that IQVIA are massive international portal that manages data. But all the same points that could be made about the IG issues that related to the patient record apply to these data as well. That although it is held in a international server somewhere, none of that can be released to any third party for any secondary uses without explicit permissions. And in opening the box of IQVIA, our IG people will have really looked at it and be assured that none of the data can be used by other persons without very clear purposes in mind. So it will not be shared with other people for mining for other data purposes.
Thanks, Robin. Thank you. So hopefully that gives you a really clear sense of, well, first of all, a new system that's being used to collect patient experience data. Always has been. I mean, and not just data, feedback. I mean, I think it's important to say it's the qualitative feedback as well. And that's always been a huge focus for us over many years. We've always very proudly shared the way in which we've looked at patient experience feedback and data and how we've acted on that. What we've got is a new system, which Robin has talked us through. And then hopefully what you've seen from Julia is the sort of function of the complaints review committee, which is particularly focused in not just on complaints, but patient experience more broadly and all the learning that we get from that. And I can see Richard wants to come in because I think this is an area that Richard's involved in as well. So Richard, over to you.
Thank you. Thanks for the presentation, Robin and Julia, and Krishni for the opportunity. Obviously, I could not make a comment when it comes to IQVIA because I've had the pleasure and opportunity of being involved in its implementation and embedding. And I just wanted to say that, you know, apart from reducing our carbon footprint, because obviously it's a more digitally based platform, it's a lot quicker to use. It offers multiple platforms, including SMS text messaging. And also, it gives us the opportunity to design bespoke surveys. So if a survey is realized that actually there's a particular area of complaints that, you know, keep coming up, we can work with them to design a specific survey that will help us to get to the bottom of what is happening and put in a mitigation. And over the three or so years, you know, it translates into substantial savings of, I think, about 200K over 3 years. So, you know, in this climate, that is, I'm sure that's, you know, music to Dave's ears. I saw him nodding there. So, yeah, really pleased with IQVIA, how it's going, and hopefully we'll get even more use of it over the years. Thank you.
Thank you, Richard. That's really good to hear. And interestingly, I mean, just as a little bit of additional insight, I happened to meet with some staff recently. I met with our Admiral nurses, who I will share some information about what I learned about that meeting. I mean, basically nurses who are specialists in supporting families and carers of people who are living with dementia. And it was really interesting because I didn't fully, you know, it's a kind of new role within our organisation. The roles have been existed for a while, I believe, in the local authority, but they're now sitting within our organisation. But it was really interesting because I was talking to them about how they get feedback about their services, and they were in the process of looking at how they could use IQVIA in exactly the way Richard described, which was sort of being able to adapt it to the kind of service they provide, because obviously the feedback they would want is from families and carers about the support that's being given. So just as a little bit of an insight that I got from conversations with staff recently. Thank you very much for a really interesting and insightful presentation. If there's anything that anyone wants to ask, please don't hesitate to put that in the chat, and we will just pick that up and follow up on that. Yeah, there's a couple more comments on there, but I mean, it's definitely an area, again, we can come back to, because obviously at some point we'd want to see more of the outcomes of the kinds of things that IQVIA, I'm still getting used to saying the word, is telling us, and how we're acting on that. And I'm sure we'll get a richer picture of that as we go through. But it's a great system, and well done to everybody for getting it implemented. I'm really conscious of the time, so I'm going to bring this meeting to a close because we are shortly needing to go across to our private meeting of the Council of Governors, which is due to start now. And we've got some business we need to cover, and I would really, I need a lot of governors on board for that, please. So I would really appreciate governors switching over to the private meeting in a few minutes so that we can get cracking on that. I don't think we'll probably need all of the time we've allocated, but it is really important because we need your approvals on a couple of things. But before I close the meeting, I just want to thank everybody who's contributed and presented. I think it's been some really rich contributions today. But I also particularly wanted to say thank you to some outgoing governors who have made an enormous contribution, not only today, but through the course of their term. So I'm going to just read their names out. We will obviously touch base with them after the meeting as well, but this is their final meeting, so I really just wanted to say thank you to Amy Clifford, David Jones, David who contributed earlier, Linda Cox. I can see Linda on screen. I know we really enjoyed having Linda as well, Rebecca Breeze, Al Richards, Sam who raised some questions earlier, Susan Bruce, and you know, really those are all the governors who are standing down. So just want to say an enormous thank you to all of you for your contributions. I also want to just mark the fact that Joanne and Richard are restanding as governors and are in the election process. So we wish them all the best in securing re-election, because we also want to recognise that Joanne and Richard have been brilliant staff governors. So thank you to them and all the best in the coming election. And the final comment I wanted to make actually is that I think this is actually Scott's last Council of Governors. Scott Adams, our non-executive director. He's still around till kind of April, early May, but it is the last formal Council of Governors. So Scott, thank you. I think governors would want to thank you. They appointed you, so and it's a long time ago now, 7 years. So thank you to Scott for all his contributions. We will say thank you to Scott at the board as well. And I know we will see Scott on several other things, but I just wanted to say this is the last Council of Governors. So thank you, everybody. I'll close the meeting, and if I could ask governors to rejoin the private council meeting in a couple of minutes, perhaps by 12:05, if I can give you a comfort break. We can make a very quick start, and I think we'll be finished reasonably quickly. So the sooner we start, the better. Thanks, everybody. Thank you very much.
Thank you. Bye-bye.
Bye-bye.
Bye.
Bye-bye. Bye-bye, everyone.
Bye.
Bye-bye.